And we are live.
Great. Hello and welcome everybody. Thanks for joining us. We're honored today to have two speakers who have been willing to take time out of their extremely busy schedules to give us an important update about public health in Iowa. We do have a great turnout today. At least 100 people are on joining us. So we do have everybody muted. If time allows, we will accept question and answers at the end of each presentation. Go ahead and use the question and answer button pop-up window at the bottom of your screen to submit those questions. Anything we don't get to, we'll go ahead and just forward along to the speakers and allow their offices to follow up with you later. I believe that's everything. I won't waste any more time, and I will go ahead and introduce the Interim Director of the Department of Public Health, Kelly Garcia. Director Garcia, thank you so much for being with us today and your continued partnership with counties. Go ahead.
All right, thanks for having me today. So it is afternoon now. It's been a flurry of a morning. I'm Kelly Garcia. I'm the Director of the Department of Human Services and the Interim Director of the Department of Public Health. And today I'm going to walk you through a couple of items. First, I'm going to give you an update on vaccine distribution, because I think that's a topic. I can't go anywhere. In fact, I was just in the hallway of the Capitol and I got stopped along the way. So I can't go anywhere without folks asking me about that. And then I'm going to walk you through, which will be more focused on the slides that you see before you, my session priorities and kind of what to expect next for public health and human services. So our health and human services agencies. First, on the vaccine, we continue to vaccinate in the state, obviously. We are really picking up the pace. And this is something that you've probably seen in the news, a lot of emphasis around. We are working directly with counties to ensure a really high throughput. That is something that our federal partners are looking to us to ensure. And I would say, Iowans are looking to us to ensure that we're having a really high throughput, that we are using every bit of vaccine that we have in the state. You may have seen in the news that a few counties' allocations were paused as we worked with them to increase throughput last week. This was not meant to be punitive. The governor just talked about this at her press conference at 11. It was really meant to identify instances where we needed to provide a bit more support or assistance and continue our momentum. And we got that. We definitely saw that this last week. I also want to let each of you know that I speak regularly with the administration, our federal partners at CDC, General Perna from Operational Warp Speed. And the governor does regularly as well, speak directly with the administration. And from them, we understand that by May, supply, which has been our state's main constraint, should be open enough to vaccinate anyone who wants to be vaccinated. And so we will continue to keep you and all Iowans updated as we get closer to that date. We are all very much optimistic. But while we are on this path right now, where supply does remain the constraint, I want to just kind of walk you through and make sure we're level setting where we are and where we expect to be. Right now, we are vaccinating in our phase 1B populations, which is inclusive of individuals who are 65 years and older, or populations who are vulnerable to high risk of exposure and severity of illness. And I'm going to list off some categories, and these are in priority order. Our first tier is inclusive of first responders, so think police officers, EMS who may not have otherwise been captured as healthcare professionals, social workers who respond to child abuse and dependent adult abuse cases and investigations. And then the next tier will be is inclusive of pre-K through 12 staff, including early childhood education and childcare workers. The next tier included in phase 1B is really directed at frontline essential workers in food, agriculture, distribution, and manufacturing, and those who live or work in a space that does not allow them to socially distance. So really focused on workers who, for example, might work in a meat processing plant. Or workers who are migrant farm workers. So they work in an outdoor space, but they live in congregate settings. And so that makes them an incredibly high risk for either contracting or spreading COVID-19. The next tier is also inclusive of individuals living who have disabilities, who are living in a home-like setting, but may otherwise be served in a congregate setting. So think like a nursing facility, and their direct care staff. And the direct care staff part is really important here. Those are individuals with disabilities living at home, but who rely on staff to take care of them for daily living needs. And then just kind of a catch-all, but any other individuals who are living in a congregate setting who were not otherwise captured in our long-term care pharmacy partnership program. We do have a tier included for government officials, including staff engaged in business in the state capitol. That may or may not be a tier that's needed. We may be working through Polk County residents age 65 plus for a while, and so it may be that this tier does not become eligible until after session, in which case we'll just kind of skip over it. But it is listed as an eligible category at the moment, but that's really just specific to Polk County. We also have a tier focused on inspectors responsible for health, life, and safety functions who are going in and out of facilities that may be at high risk again for exposure to COVID-19 or the inspector themselves exposing individuals. And then the last tier is correctional facility staff and individuals incarcerated. While we work through these tiers and get to a space where we expect supply to really meet demand in the state, we very much want you to encourage the use of all mitigation factors in your county, which this supply really does remain a scarce resource. So until then, please continue to stay home when sick, wash your hands, socially distance, and wear a mask. We would ask that you continue to use masks. We know that they are effective and work. We know that there have been a lot of lessons learned throughout our pandemic response. I think the key takeaway from our pandemic response is that we have some really key disconnects at a state level that we're working to shore up. And so now I'm kind of going to bridge over into the slides that are before you today. So you can go to that next slide, Katie. Yep, which is just our agenda. So I'm going to talk to you a little bit about some of the program alignment work we're doing between the Department of Public Health and the Department of Human Services, and what we're doing to better align the state's health and human service delivery. I'm also going to walk you through some work we've done around a Medicaid assessment, and this is my cornerstone session priority, although I have 5 key areas that I'm discussing outside of this one. And then we'll leave a little bit of time, hopefully, for some discussion before Kevin gives a presentation. So next slide. In my dual role as DHS Director and Interim Director of the Department of Public Health, I've been tasked to look for opportunities to work on connection points between the 2 agencies. And I have to say, this is the fun stuff for me. This is the work that I did back in Texas. I have worked on connection points across state agencies, government agencies, for a really long time. And I did that work at Texas Health and Human Services Commission. And there are so many connections. I'm going to run through a few that I think give some good concrete examples. So the Department of Public Health hosts the WIC program. DHS has traditional food stamps, traditional food assistance. The Department of Public Health has Title X and some other family planning benefits, and DHS is home to the general revenue funded family planning program and the Medicaid program, which is the place that most low-income Iowan women receive their family planning benefits. IDPH has behavioral health and substance use treatment, and DHS hosts community mental health and disability services. And so to have a really unified behavioral health approach in the state, we really do need to better connect the work of these 2 agencies. IDPH also has an incredible set of data and some really well-skilled individuals who can synthesize that data. And DHS has direct client services, the bulk of direct client services in the state, that we really can use those data points to, I think, better drive decisions in the way that we serve Iowans on our programs, especially in the Medicaid program. In many cases, and this is really kind of key on this particular slide, in many cases, the families that we are serving are accessing similar services across agencies, even some outside of the 2 that I'm talking about today, with really no clear path as to where to go for what, and no mechanism to connect families with the broad array of services that they have access to across our departments. We've struggled to make those connections for families. This is not a unique to Iowa situation. This is in some respects the way the federal government's aligned as well. And so the work we're going to do here is by working together to really try to make great strides that really do have a person-centered wraparound approach to serving a family, which will inevitably ensure better outcomes, and that should be our primary goal. But it also really does affect our ability to pull down our precious dollars and federal funding streams to really use those dollars, I think, more effectively. And the people in the agency are often in this type of approach, I think, better utilized as well. And so those efficiencies are also, not to be forgotten in this type of work. In terms of the work, I think there's also a significant amount of improvement that we have to make on the agency side in terms of clear communication, purposeful collaboration between our programs and between our partners at the local level with stakeholders and with providers who are delivering these services. So next slide. So what do we hope to achieve? We hope to achieve opportunities to better leverage federal funding sources, as I mentioned, and general revenue funding sources as well, but really we're looking to our federal partners here. We want to work on breaking down silos to create a unified, integrated behavioral health system. The concept here is really no wrong door, to really that a family will present a need at any door that they go into. We will equip that provider or whoever's sitting on the other side of that person to navigate a system, to better navigate a system that is pretty complicated today. And ultimately, this will drive better outcomes for individuals, for communities, and the state overall. We need to address the concerns that result from a fractured system with urgency and transparency. And so that really does mean that we recognize what is working and what we need to maintain, but what isn't working and how to address it. So the maintenance of a siloed approach to mental health and substance use disorder treatment is out of step with what we know to be true. A vast majority of our population served have lived experience in which they struggle with both sides. And so we have to make a system that is both interconnected and supports co-occurring treatment. And so we have the opportunity here, I think, to really acknowledge that. Last week, I was out in Iowa City looking at their new access center and visiting with the team there that has spent many years really bringing to life this type of work. In fact, they opened the meeting with reading a section of our request for proposal for an outside contractor to help us with this work, and really talking about the value statements that we put in that scope of work. They are the embodiment of that work, really looking at how you treat a whole person. And again, this is something that we at the state level, I think, have an obligation to do to better align what services look like in the real world. But also, we can't do it alone. We've got to have, through this process, honest conversations with our stakeholders like you to better understand what those opportunities are, but what the risks are, because certainly in this exercise, I don't want to break something that's working. I also acknowledge that there's a bit of fear out there about what it looks like to be better connected with the Medicaid agency, because Medicaid is so big and it's complicated and it takes a lot of the state budget. But we have worked through those issues in Texas. I've got a lot of experience in what that looks like. In fact, I ran community programs, which inevitably have to be deeply connected to the Medicaid program to be successful, because the clients roll on and off that program. So I think we have just a really phenomenal amount of opportunity here. I know we've got some unease as well. It'll be my job, along with our vendor who's going to help us, and I'm going to talk about that process here in just a minute. But we've got a lot of opportunity, I think, to bring everyone to the table and really work through focusing on the opportunities that are ahead of us. So next slide. I'm going to talk to you a little bit about kind of the guts of what we're working on and who we've brought in to help us with this effort. So as I mentioned, we're really going to be focusing on connection points. There are a number of other states that have different organizational structures than we do here in Iowa. And we're going to look to those other states for some best practices and really understand what's available out there, to outline the structural and operational challenges, and really make sure that that's clear. And really, I asked the governor for the ability to bring in a contractor also, because I have a lot of experience doing this work. I absolutely have some observations of what I've seen over the last 15 months here in Iowa, but I need to be a participant. I don't want to drive the conversation. I want it to be a conversation that has objectivity built into the process so that we really can have a good dialogue. And then we need a lot of help convening those stakeholders. And so our RFP that we released and is now complete, and we're about to have the kickoff meeting with the vendor that we've selected, identified some really key goals, identify clear and shared program goals, align and integrate programs, practices, and policies to improve delivery of services and most effectively leverage available federal funding sources. Identify community-based stakeholders, which would be organizations and community members and other stakeholders, to provide input and guidance to the department's programmatic and policy efforts through opportunities for collaboration and partnership, including and especially those organizations working with populations served by the departments, as well as community members who participate with even maybe as service providers, as local public health does, to those programs and services delivered by both agencies, to identify potential use for expanding funding opportunities, to engage all levels of staff, including field staff, frontline, and program staff across the departments, to establish these goals and project plans, and then create an organizational structure that optimizes the delivery of services that really reflects what happens there on the front lines, supports efficient use of team members and resources that we have internal to both agencies, and integrates the department's services, administrative services, as well with the community and what exists, again, out there on the front lines. So all of this work is closely connected to another key item that I'm going to kind of transition into. So next slide. Oh, sorry, I think I skipped over this. So we have a vendor on board, and we are working with them again to have a kickoff meeting. All of this will collate over the course of a better part of a year into a report that will have recommendations and options. And so just again, kind of honing in on the need for stakeholder engagement, and we will be in the next several weeks, probably mid-March, really taking that next step and outlining the timeline for this work once we have our internal kickoff meetings with the vendor. So we're going to take our time to do this right is really the key message here. Now I'm going to transition into our Medicaid space and our Medicaid program assessment. So first and foremost, just to level set this conversation, we do have a really phenomenal Medicaid team. We do a significant amount of work with a really lean staff. We have less than 50 stateside employees and an enterprise model that is really augmented by contracted vendor staff who perform a number of different functions for us. And this does present this situation, this kind of organizational structure within the Medicaid team presents some risk to the state. It also prevents us from doing some really important work that I think we as a state should be doing. So recently, as part of the Children's Behavioral Health Board's work, the Medicaid team, I asked the Medicaid team to perform a rate review, a targeted rate review of PMIC providers, which was a really great process. I kind of modeled what I wanted to see from the team off of what we did in Texas. And I think this was a really helpful exercise that inevitably led to a decision to include a rate enhancement in the budget. And that's precisely what I want us to be doing as a team, as an agency, for legislative decisions around targeted rate investment. And in some cases, targeted rate decreases because there may be spaces in our program. I think there are some spaces in our program where we are overpaying for service. And in order to maintain budget neutrality, we'll have to give some spaces to make some ground in other places where we need to, where we see some network adequacy issues. I envision a regular, broad review of rates across our program areas, but we don't have the staff to do that today. And while much of our work is now managing contracts, because inevitably we have shifted from a fee-for-service environment where the agency is delivering care and case management to a managed care structure in the state, many of our team members are expected to be both contract managers and policy experts while working on RFPs, and this is really very too much for any one person. So to fully assess our Medicaid program, we worked with an outside consultant to give an in-depth assessment and provide recommendations, which I think will allow us to create a new organizational structure and talk to the legislature and the governor about that investment in our agency. In some cases, I think we are leaving federal dollars on the table. And in some cases, I think we have some work to do in shoring up oversight of our external vendors. Really, I think providing depth in policy expertise into some key areas in the Medicaid program. And at this point, in a managed care rollout, what we would expect our state to be really focusing in on is more mature risk-based models where shared risk, where we work with providers on shared risk. And we really do have a more robust cost containment mechanism within that program while really working on key outcome measures. And there is a way to balance this. But again, that takes a real level of expertise and bench in our Medicaid, stateside Medicaid team that we do not have today. Next slide. So I have received that report. We had a really nice partnership with a vendor called HMA. HMA staffed this work with ex-Medicaid directors from other states. So really folks who understand what a good Medicaid program should look like. They have provided me with that report. They really do hone in on bringing in policy expertise from an outsourced model into an in-house model, really strengthening our program improvement exercises, which is inclusive of regular rate reviews, some spaces to better leverage federal funds, and to really improve program integrity and outcomes within the program. I have that preliminary draft, as I mentioned, and we are very close to providing both the governor and the legislature with our request for additional FTEs, team members, within DHS to kind of roll off of that contracted model and back into state service. I really think that this will set the stage for some targeted efforts within the Medicaid program, but this has a cascading effect to other programs. It does to the community programs that we host in this state. It also does over into public health initiatives, because Medicaid should not be ignored as a key insurer and a way to drive outcomes for populations in this state that struggle with poor health outcomes. And so I really very much want to use Medicaid as a way to drive those outcomes. This is, as I mentioned, my cornerstone priority for the session. I have others related to our facilities at DHS, field staff at DHS, state medical examiner's office at IDPH, really laying the groundwork for what a future investment in public health looks like. We have a phenomenal investment from our federal partners in public health efforts now, but at some point that money will run out. And I think we all now know exactly how important it is to have a really deeply committed investment to public health at the state and local level so that we can stand ready to respond to an emergency should one occur in the future. And with that, I think that is the end of my presentation. And I am now happy to take questions for however long you have me scheduled for, Katie. I have just a couple minutes. Or Rachel, I guess, Rachel, you're moderating.
No, that's all right. Thanks so much for the presentation. We did have one question come in so far. It's concerning MCOs versus state managed care. And the question is wondering if you're planning on moving away from the managed care and into a state run, or if you could elaborate.
Yeah, so this actually has nothing to do with it has something to do with managed care, but this is not a model where we would be rolling that back. That policy decision has been made by the state and was made many years ago. And so this is not about the way that this is about the way we on the state side oversee the Medicaid program and operationalize it. The managed care organizations are an extension of this work. But today, every day we are sending up policy documents and rate documents and a variety of other financial documents to CMS, the Centers for Medicare and Medicaid Services, for approval of how to operate that program. That takes a lot of work. It also takes a lot of work to oversee our managed care organizations. And so what I'm talking about here is the way we do that today is through this outsourced model with vendors, not our managed care organizations. What I'm talking about is really rolling those folks back into stateside so that we are really owning issues like maternal health, childhood well-being, services for individuals with disabilities, so long-term services and supports, which are the clients that live with us. They're going to live their days with us, and really making sure that we have a true vision for what the state's Medicaid program should be, and that we're making good on that. And in order to do that, the state really needs to own that vision and not outsource it.
Thanks so much. So far, I don't see any other questions coming in, so you might want to
I'm going to hop
out
off.
while you can.
Yeah. Thanks for the time today and for the opportunity to share my legislative priorities. Y'all take care and be well.
You as well. Thank you. All righty. Next, we are going to welcome the Director of the Siouxland District Public Health Department, Kevin Green. Kevin, we truly appreciate your willingness to always share comprehensive information with us and to be here at a time, like I said earlier, when we know you're super busy. So a sincere thank you for speaking to us today, and I will go ahead and hand it off to you.
All right, very good, Rachel. Thank you for that introduction. As Rachel said, I am one of the local public health administrators in Sioux City, Iowa, actually based for the Woodbury County. And one of the things is like we always open these discussions related to look at local public health across the state is I do need to say that most of the views and some of the things that I share are related to my organization, but my local public health agency is just one local public health agency. Each one and everyone has its unique characteristics and different dynamics in every county. And so what we look at doing within the local public health area, and I do appreciate hearing the opportunity to hear Director Garcia begin to share some of the things, because we too from the local level have been spending a lot of time kind of discussing, attempting to figure out what is the right path for public health within the state of Iowa. Most of you over the last year, like I said, have said to my cohorts across the state, we link together on Tuesday afternoons for about an hour to kind of look at best practices, that type of stuff. It's just this aspect as we begin to talk about is we have been forced to the forefront on many entities, and especially related to the pandemic. And I said, what is the response and ability to build from this as far as recreating a more robust, more strengthened public health system? Some of the things from the local level, in addition to working with the pandemics that we do, is that we do work through a process and with our hospitals in many cases of doing a community health needs assessment. This needs assessment is taking a look at what specifically and statistically and through data-driven decisions come as priorities that we feel need to be addressed within each and every local jurisdiction related to improving the health and the well-being of those counties' residents. We do complete ours every 3 years as a public health agency. This year we actually, this is now the third time we will have partnered with both of our local hospitals here in Sioux City. In addition to that, we have now pulled in our federally qualified health center, Siouxland Community Health, and then we also have the Dune Surgical Hospital. One of the things I will say with this is you normally doing your community health needs assessment for just your own county, but in this area of the state, it's impossible to move forward on a health-related basis without entering into a tri-state. So we're really looking at about 60 miles in diameter around Sioux City itself. But that community health needs assessment then, once those needs are identified, is followed up with health improvement planning. And this health improvement planning is basically the consortium of all the partners that are out there in what are the actions that we recommend be taken as far as to address the needs are identified for community health needs assessment. That is one of the things that is unique to local public health and that we are challenged to do every 3, and in some cases the cycle is 5 years. We think that would provide a good basis. Another thing that I would say that I also look at public health and many times talk about is we now know the impact economic impact that occur related to public health matters that go awry, such as a pandemic. I think we have to recognize, and I do kid some with our local chamber and other entities, public health is also should be considered a component of economic development. When we are looking at overall our community, we look at that members and residents are looking as far as relocation decisions. They're looking at some different demographics and data than maybe what they previously did. They are looking at the well-being indexes. They're looking at not only, it used to be our schools and healthcare is what it was. They're now looking at other amenities and opportunities that afford to them as individuals, families, and also groups. So we need to take a look and base those things on public health. Some of the things that also Director Garcia that I was interested in hearing is she mentioned some of the programs that go across in the public health agencies are pretty much all provided within your county. The Title V programs, the maternal and child health. This really looks with a series of residents. Number one is maternal health does not replace prenatal care. What maternal health does, it is supplemental in addition to that further supports these pregnant females that come across and need some sort of to assure they're getting the medical treatment, because our real goal in public health is to assure as positive a birth outcome as possible. In the child health side, we look at the oral health programs. What we want to do is make sure that any child that's trying to learn but has issues within their mouth it gets in the way. It's another barrier. It's a complication for them. So we want to make sure they get early preventative screenings and then really referred into dental care. So it's very similar to some of the things that we see in other programs, but I'm excited about the aspect to see how can we mutually support one another. In addition to that, within the scope of public health, we have the Women's Infant and Children, or WIC program. That's a supplemental nutrition program. Here at the health department also, we are one of those that in your structure as a county, in our case in Woodbury County, the environmental health component is included as a part of the public health agency. In some of your jurisdictions, and that environmental health is included as a separate entity within there. So I think it's important that we keep in mind with that. In addition to that, we have an on-site lab. It's just the VFC program, Vaccine for Children. Just yesterday, it was interesting and concerning to us that at the state capitol, there was a committee meeting that was held. And really what it is looking at is reducing the impact and some of the expectations related to the childhood vaccination program. We have all, like I always say is, we did not have, we're not looking at a mandatory vaccination requirement for COVID-19. But with measles, mumps, rubella, those types of things, it took us 40 years to eradicate polio with an aggressive vaccination program. We need to recognize the aspect and the protective nature that it has, not only for the health and well-being of those potentially affected, but look at the economic impact, our healthcare costs, lost days of productivity. Every time that there is a dependent that is sick, it has some sort of impact on those caregivers, and it may limit them with the ability to be able to work or provide other functions. So I think those are some realistic things that we definitely need to take a look at. I think, last, and not really last and foremost, but I think one of the things from a public health perspective that we need to take a look at is the whole impact that this pandemic has had. As Director Garcia said, yes, they are very focused on the vaccine delivery system and process. Each one of those processes looks a little different across the counties they're going. For example, here in Woodbury County, we basically were able to allocate and receive enough vaccine between first and second doses last week. We actually, from Wednesday, Thursday, and Friday, a series of internal clinics that we held here at the health department and 2 mass public clinics, we would have administered over 4,000 doses of vaccine in those 3 days. Today, actually, I came back from one of the clinics. We're on target today to administer another 1,600 doses. And these are the first doses going into many of the residents' arms. And as Director Garcia said, we're looking at that tier 1. We want those school teachers, first responders, law enforcement, social workers. All of those entities are the ones that we want to get protected. But then we are guaranteeing and assuring, and this is one of the things that all local public health is doing, we also need to make sure that 50% of that vaccine is going to that 65 and older population. I think another myth that's out there, there's been a lot of reports, is that we hear reports across the national and other media things about the wasted doses or potential of wasted doses. I want to let you know that within the state of Iowa, we do have these sort of rigid guidance that we are to comply with and to work with. However, though, they have given some latitude and lenience at the local level for us to be able to take a look at it, because with the fragility of the vaccine in and of itself, once there is a dose taken out of a vial, you have 6 hours to use that entire vial. Pfizer, that's a total of 6 doses. Moderna, that's 10. If you have cracked into a vial to finish a clinic for some reason, and you discover you have extra doses, we have given the opportunity and ability to be able to look for, we primarily want to look for people in the categories, eligible categories, but more importantly, we want to look at is we don't want to waste the doses, so we do get them administered. And in fact, what we called it here was an open arms concept. It was those staff members that didn't necessarily do as much direct service up front. We did not immediately give them the vaccine. We held them back. That allowed me to hold about 50 employees back. So if we ended up with these extra doses towards the end of a clinic, we could quickly and efficiently administer to them. We've also reached out to some other members within the community. When we were finishing up with the healthcare professionals, yes, we did move a little bit into some of the law enforcement with the tiers with this open arms concept. We felt it was best to skip ahead a little as opposed to waste the doses. So within the state of Iowa, we are doing our darndest to make sure that every dose that's allocated to us, we're getting administered in the timely fashion. It doesn't mean that we need to waste or to throw anything out. Also within this too, within the state of Iowa is the LongTerm Care project that came through the National Pharmacy Network. Here I only had one entity that did not sign up for it. This meant separate allocations of dose vaccine came into the pharmacies, and they actually went into the long-term care facilities, and they did administer that to both the residents and the staff, and that was both doses. That took a giant load of weight off of local public health attempting to meet that. I myself, as a larger county, it was kind of a lifesaver. Some of our small rural counties probably could have gotten out there faster than the clinic network. However, what it is by the end of January, they had essentially completed at least the first dose, and in many cases now have that second dose administered. So I think those are the things within the aspect of COVID-19. Also, thankfully, I'm very, to look at is what our numbers are showing as far as new cases of the COVID-19. We've seen a dramatic decrease within that. One of the things that scares us from a public health perspective is while we're out there planning clinics and are looking to prevent the next wave of by administering vaccine, what's going to happen to us if we end up experiencing a broad number of new cases, and how are we going to also be doing the contact tracing with that? That is a dual role that needs to be done by basically local public health agencies. So I know those are some of the challenges and the things that exist out there, but those are pieces that I would say play sort of the perspective and the overall umbrella of local public health. And I think it's important that we take a look as county officials. It is you've learned we've fielded many questions over the last 12 months, tried to give guidance, recommendations, and support for all of you, because we recognize not only are you county employees and working within that system, but more importantly, you are also county employers. And so you are trying to protect and assure that the employees that you supervise and you manage are kept as safe as possible. And so I think those are some things to take a look at. Some of the things that last night I had the opportunity on one of our local media shows, we did finish, they actually spent a full hour on COVID-19. They had myself and two local physicians in to answer questions. One of the big things takes a look at what's the timeline. Everybody wants to know, so when will the 50-year-olds be eligible? One of the things to put it in perspective is Woodbury County in and of itself has 15,600 population of 65 and older, and about 5,000 that fit into tier 1. So we have just over 20,000 individuals. If I'm only getting 12 to 1,400 doses a week, that's probably of almost 15 weeks out before we would ever consider to reach and to have served all of the tier 1 and the designated populations before we would move on to anywhere else. So you take 15 weeks out is what it is. That's probably almost 4 months. So unless that increase comes about because of the more accessible to vaccine, we're not going to be able to speed up that time frame. And we are committed to following the guidance in that. So, I mean, those are some of the things when the COVID, that's about local public health. I guess I'm more interested, as Rachel said, in responding to questions that have come up.
Yeah, absolutely. And thank you, Kevin. We do have one, and it is related to something you were talking about county employees. So do you have any idea of where county employees fall under that tier structure in terms of vaccinations, when they'll be eligible?
Right now, county employees' entire group is not actually designated in one of the tiers. There are those governmental employees, but everything that we've been told is, for some reason, that's pretty restrictive and indicative of just those that serve in operation in the Capitol. The only thing that within county employee bases that we get down to is if they would fit any of the categories that are in the tier 1. So for example, right now, if there's any county employees that are 65 and older, any of those that are county employees that may fit under that social worker category, the first responder category. Then the next tier moves into that sort of the food processing, but more importantly, are disabled individuals that reside in their residence and their caregivers. So if you have any disabled employees, that's where that category goes. The next third one then looks over is congregate shelters or congregate living situations. So if for some reason there would be county employees living in that, so it may not be overall, county employees have not been designated and identified as a specific tier or entity, but it would be some of those other qualifying factors that would relate to that. And I don't discount the fact of working with the, the public on a regular basis either. But right now, I'm fielding them all from some of the Woodbury County wanting to know when will we be able to give it to county employees. And so I think that's been one of the things that it may be a few months off at this point in time, unless I said the vaccine supply dramatically increases, or when they begin to look at, remember, it's overall phase B, 1B, if we go into 1C, and they begin to take a look at those as far as public servants, public employees, that may be a category that would actually begin to fit. But we're just looking at the guidance from the Iowa Department of Public Health related to when do we go on to that next tier and what is that tier?
Great, thank you, Kevin. Anybody else have any questions? I don't see any that have come in yet, but we will be patient and kind of wait. While we are waiting on questions, I'll go ahead and mention something quick. So ISAC in February did feature public health in Iowa in our monthly magazine, our member publication that goes out. It is a really great resource. It has a lot of really good information. You can find that on our website, www.iowacounties.org, under the Member Resources tab. So make sure you check that out if you haven't already. You should also have it in your email if you are a county employee. I don't see anything else coming in. So do you have any last thoughts or things you skipped over?
I would just say at this point in time, every local public health agency is number one, what they're looking for. And I think one of the stressors we have is with all the change and all the challenges that are coming up, many local administrators are just really unsure of where their levels of support are coming from. They are getting questions from, elected officials that come in. This is both the county and the state level. They're trying to work to address those, to acknowledge in those. The public is getting what I call sometimes in a rabid phase related to trying to get access to the vaccine. But I know one of the things is that the challenge with that is, not enough vaccine. We're not going to be able to, deliver as quickly as we're doing. So one of the things that I would actually say is, as you may interact or reach out with your local public health agency, please lend them what support that you can. I think it's important that they hear and they understand that as whether they are a county department affiliated to the county or even a hospital-based one, it's important that they hear some things, that take a look and they understand, and that they know there's other people out there that are kind of behind them in some of the work that they're doing. And there's a lot of calls that they field related to that and the support.
Thanks, Kevin. We did have a couple more questions come in. Number one, you got a kudos from an anonymous attendee saying you did a very good job. Secondly, so treasures have come up specifically in the work they do with the public, specifically related to driver's tests, entering public cars, just being face-to-face with the public more and more. So I don't know if you had anything more to elaborate, or it just kind of went down that list and into the 1C, or?
I mean, there could be exceptions to some of this too. I mean, I know some of the things that we have worked with is what I took was the open arms sort of concept. We've looked at some of those that may closely qualify. And I'm not even sure within the driver's license testers when you're doing it. I mean, just like, for example, in me trying to figure out we have our transit system that's here. Well, overall transit drivers do not necessarily qualify, but when you drill down into that, one of the things that we find out is that in Sioux City, because of more of an urban setting, there are those transit drivers that are consistently and regularly on a daily basis transporting a high percentage of the students that go to school in the buses or the transport vehicles that they're driving. Therefore, when we drilled down and we took a look at that, we sat down with the transit. That was one of the things that we don't have all transit drivers who are eligible, but we could easily link that to the educational realm, that we felt that the 18 that fit in that category that provided that type of service, that's something, I mean, what's the difference between, we were also providing it to our rural bus drivers in our smaller school districts. So it was sort of a link that we had because they were school employees. That was justified. In this case, they're providing the same functional service. So we have worked with them that we're going to work them in to get them the vaccine in that sort of priority, more related to the tier 1, just because of the role and the purpose. So I don't know if the driver's license drive testers is an option, but yes, I do understand that they're working and they are calling into the public's cars. There is a close, proximity. The one thing that I would actually make sure is that, are there requirements that both everyone that's within the car wear a mask? That is one of the protective natures, and they're doing some of those mitigation efforts.
Thanks so much. One attendee was wondering if you could elaborate more on the load that local public health agencies have taken on, some of the hours they've been forced to work, just really what it looks like in you guys' day-to-day lives over the past year now.
I will tell you this is that it has, if you allow it to be, it can be a 24/7 job. There is a potential for some of that. We sat down early as a local public health agency, and we talked about with our incident command staff, making sure that we're doing not only self-care, but watching out for one another. But I know there are some administrators that, I mean, it's 6 to 8 hours for sure every Saturday and Sunday in there, 8, 10, 12 hours during the week. There's some burnout that's occurring within that. There are phone calls that are coming in. Some of them just, like the public's calling at home with the same questions related to when can I get the vaccine? There was a lot of individuals calling just with questions, just as far as, employers trying to figure out that during the time when our case counts were growing. I have this active case. Okay, this is what they do. Who do I need to have isolated? Who I need to have quarantine? How do I do all those types of things? So those were a lot of consultations that were going on that I think that we had to do, and we felt the need to do, because many of these, as far as the employer spectrum, you needed to know answers to give guidance to either that employee of yours, and then also it was due diligence to make sure that you protected the coworkers of that individual. And so I think those were things that we spent a lot of time beginning to work on and to do. Over the past with the vaccine clinics, every county has operated differently. What I will tell you is in the clinics that we've done, my healthcare community has stepped up. Every clinic that we do in a mass basis requires a minimum of 88 staff positions to be filled. Last week, when we did 2 broad-based clinics, I had 5 staff there, and the other 83 all came from volunteers and the clinic personnel. Today, we have a few more, but I think it's how you, interact and get that organized. But yes, it can simply consume your life. The other part that I've avoided, not only because of mitigation, I really try to stay out of, I send my wife to the grocery store. Because they recognize you even with the mask on. And even if they don't know, there's been enough media sort of coverage and that sort of stuff that I can't get through any of those places without having a COVID conversation. And so those are the other parts. Public health is happy to do that. It's a role of what we should do with public education. But at some point in time, when you run in and you've got a quick errand, you need to get this done, it evolves into another hour or so of work. And so I think those are all some of the parameters. And so you're never really, even at this point in time, now that we've opened up and going to church, people have more questions. They want information. That's what they're seeking. So really, once you're labeled as that public health professional, there's a potential at any point in time. Thankfully, one of the things that we stupidly did is we followed the trend, but it's one of the best things we did is we got rid of our landline on our phone. It seemed like at the point in time, we just sort of did it for a financial kind of thing, cell phones, technology, connectivity. We got rid of the landline. But the one thing that I discovered is that was last November when all this broke in March. That was the number everyone had published within a phone book that would have just rang off the wall. And so I can't believe the number of people that said, well, I tried to call and it says the number is disconnected. And I said, well, yes, it is. So I think those are things that some of the outcomes and outgrowths of all of this pandemic that all public health professionals face at one place or time.
And I say thank you. Someone in the chat also said thank you for sharing what it truly is like. I think, unless I see any other questions come in, we'll go ahead and close it there. Again, Kevin, thank you. Thank you to all the public health professionals. Thank you to all the county officials. We know many others of you are on the front lines as well. We're here at ISAC to support you. So please reach out to us if you need any help, assistance, if there's anything we can do for you. Special thanks to Kelsey Seaburn and Katie Cook, who put on our educational programs and helped put on this webinar. They do a great job behind the scenes. And yeah, thank you for attending. The recording will be available if you want to share the link. It'll be on our website. Kevin, do you have any last minute words of wisdom?
All I will say is when you're a public health professional likes to take a few days off for vacation, just understand that it's done out of a mental health perspective. And I only say this because today is actually the last day on, and I'm actually going to take a week off. So I call it the mental health day. I've had staff that said it's time for you to get out of here, but I hate leaving in the midst of all the activity. But that is one of the things about the system is I have great backups that are going to step in willingly and take care of things. And that's one of the luxuries that I enjoy working here at Solon District Health Department. I know not all local public health, but then even for you as supervisors, I would say I said ISAC members, is that one of the first things that I told staff is I will need no approval for vacation carryover. We have vacation, maximum vacation. And I did tell everyone, I said, we have to, for our own mental health, utilize that to get away. It's the break we need. It's the self-care that we need. And so I think each and every one of you have been through tremendous stress over the year. And I can't say, even when Director Garcia was talking about the mental health issues, DHS and that sort of stuff, I think it's important that we each watch out for ourselves to assure we get that time off, we get a break, we get away from this sort of stuff, and just be able to kind of recompose ourselves and come back, I guess, a little more energized to deal with some things. And that's not just public health, that's any of you as public officials. And I think it's important we keep our mind around that.
It's a great way to end. Thank you very much, Kevin. And thank you all for being here. We'll see you again soon.